When it comes to advancing health equity, diversity, and inclusion, Cone Health in Greensboro, North Carolina, the winner of the AHA's 2020 Equity of Care Award, is a model of success. The organization has been recognized for its innovative efforts to integrate health equity practices into physician training and board governance. Today, we'll learn how Cone Health set out to accomplish and achieve its goals to better serve all patients in the communities it serves. Welcome to Advancing Health, the podcast of the American Hospital Association. I'm Tom Hetterly, senior writer with AHA. Through a careful process involving data collection and patient-centered interview techniques, Cone Health has pioneered educational sessions for its physicians about social and racial influences in healthcare, while continuing to deliver high-quality care for patients of all backgrounds and cultures. In this podcast, Darren Henson, Director of Operations with the AHA's Institute for Diversity and Health Equity, is speaking with Laura Vail, Director of Health Equity at Cone Health, and Dr. Alvin Powell, Chief Health Equity Officer at Cone Health. Also joining the conversation is Paul Jeffrey, President of Cone Health's Wesley Long Hospital. Jeffrey also served as its inaugural Chief Inclusion Officer. Today's discussion will focus on Cone Health's process and creative steps hospitals and health systems can take to achieve similar success. And now, over to Darren.
Thanks, Tom, and welcome, everyone. Today I'll be joined by Laura Vail, Director of Health Equity, Dr. Alvin Powell, Chief Health Equity Officer at Cone Health, and Paul Jeffrey, President of Cone Health's Wesley Long Hospital. Thank you so much for taking time for this important conversation. Hospitals and health systems are striving to improve health care quality and advance health equity among diverse populations through a number of sustainable strategies. At Cone Health, one such strategy is the requirement for physicians to take health equity courses. This received unanimous support from your medical executive committee. This is very innovative and is the first such example that had come to the attention of the Equity of Care Committee, where in addition to executive leadership support, here we now have the physicians committed to health equity. We're especially delighted to have you share your journey in this one innovative strategy to advance equity of care. So tell us a little bit, how and where did this emerge for all of you?
So this is Paul. I have to go back in time to be able to give you a context of how this came about. And it has to do with the fact that some time ago, around the year 2010, Cone Health decided that we needed to do an assessment of our culture, what is important and what is rewarded. That assessment basically gave us quite a lot of information about who we are and who we're being versus who we want to be. What we discovered in that assessment, and the assessment was of the entire organization by having multiple leaders and frontline employees, as well as physicians, participate in that assessment. And we learned people were perceiving the organization to be. And that was a culture in which volume and cost controls were the important matters. That was not inspiring whatsoever to anybody, is what we learned. The organization was pretty much accepting that we were just a good health system, but not one that aspired to do great for our patients and our communities. And continuing that work, who do we want to be? We said that we wanted to make sure that our employees and our physicians, we were aligned with them and vice versa. And so we worked for a year plus on who are we going to be? Who do we want to be? And that became a patient-centric national leader organization. Work began with that bold initiative. What do we have to do in order to improve the quality of care? So in specific, we were looking at different arenas and within the quality arena, I should say. And that is, how are we doing with hospital infections? how are we doing with mortality? And with that, more detailed work started on how to improve all these different areas of quality and patient experience. And we did an assessment, another assessment of our physicians as to how they saw themselves when in reference to equity of healthcare. And with that, I will now want to pass this on to Dr. Powell to talk about what has happened with the actual initiative that of taking it to our medical executive committee.
So just briefly, the medical executive committee is a governing body of the medical staff of a hospital, and it consists of medical staff leaders such as the chief of medicine, chief of surgery, chief of pediatrics, psychiatry, emergency medicine, and so forth. And those leaders and the medical committee are charged with maintaining a high quality of care and safe care within the hospital. So they're focused primarily on quality and safety. And the medical executive committee is responsible for making sure physicians maintain appropriate professional standards of medical care, and when appropriate, to require additional training. And so this is where we are, and this is how we got to this point. And that was the mechanism by which we were able to request the opportunity for cultural competence as an educational requirement at our institution.
Excellent. Thank you so much. I think you addressed who some of the key leaders were in and the relationships that were needed to move this vision and this strategy forward of addressing some of the inequities that you were seeing amongst your patient population and in the communities around you. I'm wondering, were there any sticking points that arose in the discussions among the medical executive committee when you first were looking at this idea of addressing some of the inequities of care and the quality outcomes that you were seeing?
Yes, Darren, thanks for that question. There really were some sticking points that arose. And let's begin in 2016 when this initiative was brought before the medical executive committee. Basically, we got an emphatic no. Well, with a little bit of give in the sense that the docs were willing to take maybe 15 minutes of education, 15 minutes. Or the docs said, well, you new docs can take their requirement, but we don't need it. And just think about that when you think about physicians with their whole life dedicated to good care to everyone, the egalitarian nature of healthcare and what we do for folks. To think of ourselves as not being able to give the same care to everyone is difficult. And so that was a challenge at that particular time. And so with that pushback, we just sort of said, okay, this is not the time. And this is very important from a historical perspective. I think it's important nationwide is that Cone Hospital has an important legacy that many people are not aware of. But like many other institutions throughout the country, Cone Hospital discriminated against people of color during the era of Jim Crow. In 1963, there was an important lawsuit where African-American physicians, dentists, and patients sued Moses Cone Hospital and another hospital in town, Wesley Hospital, for the right to gain access to be able to treat patients in the hospital and for those patients to be cared for in the hospital. The initial lawsuit was lost by the physicians and the patients. There was another lawsuit. It was appealed to the Fourth Circuit Court of Appeals. And on the basis of the fact that Cone Hospital and Wesley Hospital had about $3 million from the federal government for construction, the physicians, dentists, and patients won that lawsuit. It was a landmark lawsuit called Simpkin versus Cone, and it was a precedent for over about 260 other cases to desegregate hospitals throughout the United States. That suit took place in 1963. 6 months or so after the MEC refused, the Medical Executive Committee refused to allow cross-cultural education to be a mandate at our institution, our current CEO, Terry Aiken, apologized to the last surviving plaintiff of that lawsuit, Dr. Alvin Blunt. That was a really big deal for our community. That was a really big deal for Dr. Blunt, for Dr. Blunt's family, and for all the other family members of other plaintiffs of that lawsuit. It was powerful for our community. It was an opportunity for us to develop some trust within the community and to separate ourselves from the past, this institution from the past, and move on with a new initiative of health equity as opposed to holding on to the past. And we made that important. We made it relevant. And we explained current disparities with data that we had accumulated, because now we were collecting race and ethnicity and language on every single patient that came into the hospital. And we were able to document and show the medical executive committee that we, in fact, did have disparities based upon race and ethnicity in our institution. We talked about unconscious bias. We explained how that was, in fact, real in healthcare. And the medical executive committee, based upon the history, based upon the data, based upon the stories that were shared with us, unanimously agreed that cross-cultural education, cultural competence was important, and they agreed to physician mandate throughout the health system for education in that area.
Wow, what a really rich and powerful story and history there, and an incredible example of newfound leadership in building new bridges, restoring and fostering newfound trust in your community. Tell us a little bit more about the courses themselves. So is it a singular required course in cultural competency training for the physicians, or are there other courses that they can choose from?
That's a great question, Darren, because I think even the medical executive committee, they were curious about this. Was it going to be prescriptive? Was it going to be open? And in the end, after some good discussion, what we decided is that this didn't need to be prescriptive, that each physician has an idea of their patient population and kind of their comfort level with things. So some feel really comfortable with using an interpreter for the deaf. Some might not feel comfortable. And so being able to have the flexibility to take a course that might give you a greater comfort level, we thought that was important. The racial inequities that Dr. Powell spoke of, those are big in our community and in our area. And so really wanting to make available racial equity courses, helping people to understand racial disparities and racial disparities in health, how there is an element of justice at the bottom of all of this. So we have made courses available in person. Our local AHEC has developed some social determinants of health courses, and they're being offered at lunch. Our physician practice group has put in place some webinars, some lunchtime webinars. Last month it was about interpreter services, and this month it's about empathy, and then next month it's about discrimination in patient services. There are online courses. What we have asked the physicians and made as the requirement is that they would take two courses that are worthy of the 2 CMEs, and that they would do that for each reappointment cycle. So this is something that they will commit to, and they'll have an attestation statement. Of course, it could be audited. They know that. They may have to show certification for, taking the class or something like that. But really giving them some flexibility, we felt like allowed them to really up their competency with their own patient population.
So it sounds like some of the courses are in person, and there's also offerings for webinars and other computer-based learnings as well for these. And I think I heard you say that it's 2 hours equal to 2 continuing medical education units, or CMEs.
Correct. That's what we have in place.
Great, thank you. Who is required to take these? Is it just employed physicians only, or is it all credentialed physicians and advanced care practitioners there at your hospital or health system?
Sure. It's a requirement for all physicians within our health system, and going to the medical executive committee was the way to get that done. The medical executive committee dictates the requirements for physicians throughout the health system, whether they're employed or not. We felt it was very important, not just for physicians to have a requirement, that we felt that if we wanted to really impact health equity within our community, that it needs to be led by the physicians. And so that's why we took that route.
So it sounds like some of the key people involved in this were certainly your Chief Health Equity Officer, so yourself, Dr. Powell, CEO there, Paul, or the president of the local hospital, and the head of the Medical Executive Committee. Were there other key leaders or relationships that were important to making this successful?
I think Paul and Laura talked a little bit about the Physician Health Equity Council. I think within that council, there are a host of doctors that were involved with this process. But the drivers to get it through was the Medical Executive Committee. The chief surgery, medicine, pediatrics, all of those folks needed to lead. And they were really the drivers to make it really happen, to get the final approval where it became a requirement.
I'm curious, tell me a little bit about the feedback of the experience from the physicians themselves. What is it that they have said about this? And I'm wondering, too, as a follow-up to that, are there any metrics or program evaluations yet that you can share from the physician experience?
The feedback, that's a real difficult thing to measure. In healthcare, docs, we have to take a lot of continuing education. And so we don't really talk much about what we do as far as maintaining our certifications. But what I will say is very interesting is when we talk about race and ethnicity and inequality, that's a powerful thing to talk about and discuss. And as we have done racial equity training within our institution through our Racial Equity Institute here in Greensboro, there's a 3-hour module basically that some of us have taken. That has really caused a lot of discussion about race and social injustice and educational inequalities, criminal justice disparities and employment issues and healthcare disparities. And it's raised the awareness of what's going on in America today and how all of that impacts healthcare. And so it's a new discussion. So I would say it has raised that awareness. People are talking about it. It's a good thing.
So Darren, I'll take the second half of that question, which was, what's the impact in terms of what are we measuring? And Dr. Powell's comment about you sit in a room and we're in these big meetings and people are talking about their true north metrics and somebody will stop and say, that mortality metric, did you measure it by race? Are we looking at race, gender, age? We are no longer the voice that raises that question. And so we count that as measurable progress, that we've enrolled people in the health system into this conversation that they understand. So back to Paul's comment about there was a time when we were not as patient-centered, when we weren't looking at every patient, all patients. And so there's a real shift in our organization. There's been a culture shift, which really had to occur first for this health equity work to take root and blossom like it has. I sat down with the OBGYN service line about this time last year, and they wanted to have a health equity measurement on their scorecard. So we talked about what it might be, and we worked through all that. And watching that take root, they ended up choosing to measure the hypertension. They had a racial disparity, hypertension readmissions postpartum. So that was what they decided to add as their metric. But their approach was really this anti-racism approach. They brought in a speaker to talk about bias with the physicians, and the nursing leaders presented data. They presented stories, how this is impacting our patients, made it real, and then it led to all these clinical changes and protocols so that we could actually measure in the end that these initiatives are making a change.
And Darren, let me add to that a little bit as well, because I think, we talk about things, it's hard to measure the impact on health equity from a physician perspective, but I think what we're able to do now is we're able to measure some of these things system-wide. Because of health equity, we've put in place lots of things, again, measuring race, ethnicity, and language, identifying every single patient, if we can, from a demographic perspective. And then we have our enterprise analytics team that's in place now. And with the power that they have to utilize our powerful computer system, they can look at disparities. And so we're seeing these things and we're looking at these things. And it's so natural now for us within our health system to look at these things. So when we talk about systemic racism, it's sort of pervasive. When we talk about health equity, we have to be very intentional about doing this work to unwind that process that results in the disparities. And so we're doing that intentionally, and we're talking about it, and it's happening. And it's happening, and it's not unnatural now. It's not an odd thing anymore. It's part of the culture of what we're doing.
The impact you all are describing is really the impact to the culture of your organization and the types of questions and the dialogue that is even happening amongst your own selves, amongst your team, amongst your clinicians there. Great stories, great examples of how this initiative that you all began is making a real difference there at Cone Health. I'm wondering, can you share any future plans or ideas that build upon this initiative to advance the equity of care by the providers there at Cone Health?
I do certainly believe that we need to continue to try to create the culture of equity being a systemic part of everything that we do. Everything that we think about, we should be thinking about equity. One of the things that we're looking at right now from the perspective of leadership is we're trying to put someone who's really an expert on cultural competence, unconscious bias training, and so forth, and for that individual to come in and with a group of our leaders, to train the trainer so that we can make this sustainable within our health system. We can do it ourselves and continue this process of implementing educational programs where we can keep this message going, keep this culture going. That's something we're doing. The other thing we're doing is really looking at health inequalities in communities of need. Almost every community in the country has a community that has a medical desert. So what are we going to do in those particular areas? We know they exist. Everyone knows they exist. So what can we do? So we're building a mobile strategy to go into these communities of need. And then we're looking at brick and mortar. So mobile is not a solution. It's a bridge to something more permanent. And so we're looking at those kinds of things. And also we recognize that there needs to be diversity with respect to who are the caregivers within your institution. Again, demographics is very important. Those being cared for need to be cared for people who resemble them as much as we can. The caregivers need to mirror the community that they're caring for. And that's something that we're working on as well.
As you talk about the community and going out into the community, can you say maybe just a little bit about how community partnerships have aided your effort to improve the equity of care?
So we're in the process of looking at clinical care and recognizing that we've not always done a great job of being in the communities of need and communities of color in terms of building bricks and mortar clinics. So we're in a humble inquiry phase right now with that work, and it has allowed us to spend time with our community partners. Yesterday we had a call with United Way. That was in the afternoon, and in the morning we had a call with a free and charitable clinic in town. Just basically asking them, how do we supplement what you do? You're doing great work. How do we not sabotage what you're doing? You're in the community. How do we share that if health equity is really our goal and we all unite around that, how do we work together? For us as a health system, that is going to involve thinking differently. It will involve different measures of success, different marks of distinction. We've heard from some community partners, they said, if you could just give us a nurse practitioner, if you could just give us a PA. So I think there are all kinds of needs that we've learned about by really getting close, talking with the FQHCs, really just talking with people that have more expertise than we do in delivering care in the community.
Great examples of reaching out to the community, partnering ever more closely with them to help advance health equity within your institution and within the broader community. So tell me also, in light of these strategies that you had prior to the COVID pandemic, how have they helped, or how have you seen COVID impact your equity strategies?
It's a good thing that we had people enrolled in this conversation and in these strategies and tactics and things beforehand. It's really good that our culture was in place before COVID came and upended really everything we've been doing. As the national conversation shifted and people were more aware of essential workers and why are essential workers Black and brown people, and so they were aware of these social and economic inequities and how those were then impacting health and how come underlying conditions were affecting Black and brown people at a greater percentage. I think as those conversations were occurring on a national stage, it was just really good that we'd already had those conversations here. We were enrolled in that this is important. It really drove it home, I think, because we saw this happening on a global stage, but on a national stage. For us, there was no hesitation. When we began to see these inequities arise, we quickly partnered with the faith community went to historically African American churches and said, we'd like to offer COVID testing. We'd like to offer it for free. And just really developing those partnerships and trying to make a difference. I think trying to really see that health equity is important, really connecting with our Hispanic Latino organizations, as we saw that was one of our big disparities here in our community. Just working on translating everything, all of the signage and all of the flyers and commercials and radio ads, and just really making sure that there was an emphasis on how do we make this really accessible and equitable for all of our patients.
Thank you for that. Great strategies with the culture that you had, strategies that you deployed right away to help address this incredibly difficult situation of the COVID-19 pandemic, and the inequities that it has exposed are great examples for many other member organizations. Laura, Paul, Dr. Powell, thank you so very much for this informative exchange about Cone Health's award-winning methods to advance health equity, diversity, and inclusion that may serve as a model process for other hospitals and health systems to consider. It's been a real delight, an incredibly engaging discussion.
Thank you, Darren. We enjoyed being with you today.
Thanks for allowing us to have a conversation.
Darren, thank you so much. This was very inspirational to be able to go through this all over again and share with someone else.
Thank you for listening. For more information from the Institute for Diversity and Health Equity, please visit our website at ifdhe.aha.org.